Hello, I am Ismael Gestopa and welcome to my case presentation on the antipsychotic drug Thorazine with the generic name chlorpromazine. Thorazine belongs to the first generation antipsychotics or typical antipsychotics, which were the first antipsychotic drugs discovered in the 1950s. It is a dopaminergic antagonist that helps block dopamine receptors to regulate psychotic conditions. Consider a low-potency drug that may need higher doses for use. Thorazine is used to treat psychosis. Chlorpromazine is listed in the WHO model list of essential medicines for psychotic disorders. It helps alleviate the symptoms of bipolar disorder in schizophrenia. This is also FDA approved for chronic hiccups as well. Off-label use, it is used to treat delirium and insomnia. It causes non-neurologic side effects, but other side effects are extrapyramidal symptoms, and prolonged use can also cause ocular diseases. It can be administered orally, intramuscular, or intravenous injections. The administration and dosage decision depends on the condition and needs of the patient. Now for case study number 1, when to use Thorazine. For the identifying data, the first case study is when to use Thorazine or chlorpromazine. The patient, Mrs. C, is a 57-year-old Filipino-American who abruptly stopped going to her place of employment and also participating in the church activities, for she was complaining about terrifying visions that haunt her. She was brought for consultation by her 30-year-old son, as the son was concerned that Mrs. C would have difficulties in articulating her condition due to occasional disorganized thoughts and speech. During the consultation, Mrs. C was able to divulge relevant personal history that helped her in her diagnosis. For the history, Mrs. C's childhood was focused on religion. Her immediate family and even several relatives back in the Philippines were members of an obscure religious movement that believes that the world has nearly entered the end. Mrs. C was often exposed to discussion about violent scenarios and was taught to strict obedience to the religious group so as not to be hounded by the terrifying visions. While working as a high school teacher in the province, Mrs. C married his colleague, Mr. C, even though her relative did not approve the marriage because they are not of the same religion. She was removed from her religious group, and this caused a toll on her mental health. She did not seek therapy and just resorted to constant praying. The couple migrated to the United States months later, and they have to adjust to the new culture. Years passed. Despite being already established, Mrs. C is still troubled by her past religious belief. Medical history is unremarkable. No history of allergies. Family history is unremarkable. This is also her first consultation. For the findings, during the consultation, Mrs. C was cooperative and answered questions easily, but sometimes disorganized thoughts were observed. Mrs. C is mainly bothered by the terrifying visions, as she thinks this emerged to punish her from straying from her religion. She also expressed sadness because she was not able to reconcile with her relatives before migrating to the United States because of her marriage to Mr. C. She expressed sadness because of the terrifying visions that haunted her most of the times. She experienced severe headache every now and then, which she claimed may be due to inadequate sleep. To rule out other likely causes of her conditions, cranial CT scan and urinary toxicology tests were done. The former test was done since she has frequent headache to ensure that she does not have significant neurological abnormality. Meanwhile, the later is to ensure that Mrs. C is not using recreational drugs, and both tests yielded normal results. For the diagnosis and treatment plan, the symptoms exhibited by Mrs. C are consistent with schizophrenia because of the following: visual hallucinations, disorganized speech and thoughts, and disturbance in social functioning, which is no longer showing up to both work and religious engagement. With Mrs. C unremarkable medical history and with the absence of allergies, the pharmacological treatment given was Thorazine or chlorpromazine. This FDA-approved antipsychotic is usually taken orally, but may also be administered as intramuscular and intravenous injections. Since this is Mrs. C. First time to be on an oral antipsychotic medication, the standard dosage of 25 mg twice a day gradually adjusted and maintained to 200 mg per day and taken regularly. Non-pharmacological treatment is a combination of cognitive behavioral therapy and family therapy were recommended. CBT primarily helps patients identify and modify negative thought patterns and has been found to help in the improvement of the self-confidence, self-esteem, socialization, and overall quality of life. Through family therapy, the collaboration between the family caregiver and healthcare provider is strengthened. For the overall discussion and patient teachings, patients diagnosed with schizophrenia who come from highly religious backgrounds have been found to initially experience difficulties in establishing service contact and also in adhering to their treatment. The non-adherence can be explained by a clash between religious convictions and clinical decision according to Boras et al. Year 2007. The Philippines has a rich Catholic culture and history. It is also a country with a lot of religious beliefs. In the case of Mrs. C, rigorous supervision is vital in order to ensure that she adheres to the prescription of Thorazine or chlorpromazine and consistently attends session of CBT. Family members involved in Mrs. C care are the son and Mr. C must also be consistent in attending sessions of family therapy. For case study number 2, when not to use Thorazine. For the identifying data, for the second case study that focused on the non-use of Thorazine our patient is Mr. K, a 38-year-old Chinese-American male whose daily life was affected because of visual impairments. It should be noted that Mr. K is diagnosed with paranoid schizophrenia and was diagnosed at the age 19. Prior to diagnosis, it was reported that he had delusions, auditory hallucinations, tremors, and sometimes agitation in social settings. His current medication is a combination of Thorazine and Artane, which has been taken for 18 years. According to him, this combination improved his symptoms and made him feel functional. For the history, the patient has history of stay in the emergency department when his mother brought him in after having a manic episode. He previously took trifluoperazine, but there were no significant changes to his symptoms, so it was discontinued. Psychosis symptoms, however, were most notable after his parents divorced. Mr. K mentioned that he began drinking alcohol because of this, but he made an effort to stop after experiencing motor coordination problems. Medical history was insignificant, no reported allergies. Family history is insignificant, but maternal grandmother was reported to have visual hallucinations. For the findings, for the most part, Mr. K is cooperative, but he expressed exhaustion because he cannot see well. His greatest fear is blindness, and because of this, he was having suicidal thoughts. He was also skeptical about replacing Thorazine since it worked well for him for a long time. During the physical exam, he claimed to be light sensitive and have occasional headaches. A visual acuity and slit lamp exam were done on Mr. K to clarify the cause of his blurred vision. A systemic examination, hemogram, and liver function tests were done to check for abnormalities and the possibility of underlying diseases. A serum electrolyte test was also done to check for electrolyte imbalances that may have affected the ocular manifestations. Except for the ophthalmological exam, all tests were also normal. For the diagnosis and treatment plan, since the lab test results were normal, it was determined that this prolonged use of Thorazine is the reason for his visual impairment. For the pharmacological treatment, prednisolone was prescribed to alleviate some symptoms of visual difficulties. Thorazine was also replaced by olanzapine using cross-tapering method. Glucose and lipid tests and weight monitoring are especially important because olanzapine is associated with metabolic adverse effects since it is an atypical drug. Since a cross-taper method is being used, there should be constant monitoring for dosage changes and withdrawal symptoms. Ophthalmological visits are also recommended for follow-up tests. For non-pharmacological treatment include CBT, and ACT to help combat negative thoughts since the patient showed negative symptoms. Family therapy is also included to provide support in understanding of the patient's present condition. For education, self-management is important to monitor the possible effects of olanzapine, and external support is important to ensure he is safe and supported. For the overall discussions in patient teaching, Thorazine has been part of Mr. K's combination of medication to treat paranoid schizophrenia for 18 years, but it is no longer an appropriate treatment for him since he started having visual impairment. As previously mentioned, ocular disease are one of the risk factors for the prolonged use of Thorazine. For the most part, he is cooperative but skeptical since Thorazine has worked well for him in the past. Olanzapine is the chosen alternative for Mr. K because it's also an antipsychotic drug that used to treat schizophrenia, but it's non-phenothiazine. This can help stop the visual impairments from the getting worse. Other than that, Mr. K has no family history or current record of metabolic diseases, which could cause adverse side effects with olanzapine. In choosing this drug, we also took into account Lee et al.'s study where olanzapine caused a remarkable improvement in the symptoms of Asian patients with schizophrenia. Compared to typical antipsychotics and risperidone, olanzapine has the best result in improving negative symptoms and was the least likely to cause extrapyramidal symptoms. Ethnically, Mr. K is a Chinese, and risperidone or other atypical drugs might have worked fine for him, but as an Asian, olanzapine would work best for him. In conclusions, now that I've reached the end of my case presentation, let me briefly state my takeaways from this activity. In patients diagnosed with schizophrenia who have highly religious background are known to initially experience significant difficulties in seeking professional mental help and in adhering to treatment. Sociocultural and spiritual factors can influence a patient's involvement in his or her own recovery, hence the importance of continuous patient education. Thorazine or chlorpromazine is the standard antipsychotic drugs prescribed to patients diagnosed with schizophrenia. Its side effects, however, require healthcare provider to closely monitor a patient. And that is the end of my presentation. Thank you so much.